All right, let's get right into it. Today, we are going to walk through the complete diagnostic imaging pathway for lung cancer, all based on the official clinical recommendations. Think of this as your step-by-step guide, from the moment you first suspect something is wrong, all the way to a final diagnosis.
So let's picture this. A patient walks into your clinic. Their symptoms, they're really pointing towards lung cancer. Now, what do? What's the first step? And more importantly, what's the correct diagnostic path to follow to get them the answers they need, fast? That's exactly what we're going to map out.
Okay, so here's our game plan. We'll start with the initial exam, X-rays and CTs. Then we'll get into the super important topic of cancer staging. After that, we'll cover the search for metastases using things like PET-CT and MRI. Of course, we have to talk about morphological verification, which is just a fancy way of saying biopsy. And we'll wrap up with screening and follow-up. Let's dive in.
All right, Section 1, the initial examination. So when a patient's symptoms have you worried, these are the first tools you're going to reach for.
Yep, the journey almost always kicks off right here with a good old-fashioned chest X-ray. Why? Well, it's everywhere, it's quick, and it is the officially recommended first-line investigation. It's basically your go-to triage tool before you decide to bring out the bigger, more advanced imaging guns.
But what happens when you get that X-ray back and it's either totally clear or maybe there's a weird little shadow but nothing definitive? Your gut, your clinical instinct is screaming that something's not right, so what's your next move?
Well, the answer is computed tomography, CT. This is the primary imaging method for checking out lung abnormalities. It's really the cornerstone here. CT gives us these incredibly detailed cross-sectional images, basically a slice-by-slice view that can reveal all sorts of changes that you just never ever see on a regular X-ray.
And this really lays out the difference perfectly. The chest X-ray, that's your first-line screening tool. But the CT, that's your primary diagnostic tool. Think of it like this. The X-ray shows you the outside of the house, but the CT hands you the detailed architectural blueprints for every single room. It's just a whole different level of detail. And you'll see here, both have a C level of evidence, which means they're backed by strong expert consensus.
Okay, so you've done the imaging and you've found a suspicious mass. Now what? Now comes what is arguably the single most important step for that patient's future: staging. We absolutely have to figure out how far the cancer has spread.
And to do that, we use the T&M system. Now, this isn't just some random alphabet soup. It is the universal language that describes the extent of the cancer. T is for the primary tumor itself. N is for regional lymph nodes, has it spread there? And M is for distant metastases. It's how everyone, everywhere, gets on the same page.
So, to figure out each piece of the TNM puzzle, we need the right tool for the job. To assess the tumor, the T, we need a CT with IV contrast. For the nodes, the N, we're looking at PET-CT. And for metastases, the M, we use both PET-CT and a brain MRI. Each one gives us a crucial piece of information.
Let's zoom in on that last part, searching for metastases. Because finding out if the cancer has spread, well, that's a huge fork in the road when it comes to deciding on treatment. And for that, we use PET-CT and MRI.
So PET is the recommended method for checking out lymph nodes and distant metastases. And it is a seriously cool piece of tech. It basically combines two scans in one. You get the anatomical map from the CT, and then you get this functional imaging from the PET part, which lights up cells that are metabolically active, like cancer cells.
And get this is why PET-CT is such a game changer. The clinical guidelines actually say that using PET-CT changes the stage of the cancer in about 1/3 of all patients. Think about that. For 1 in 3 people, this scan completely alters their treatment plan. It can be the difference between heading for a surgery that won't work and getting the systemic therapy they actually need. It's huge.
But for all its power, PET-CT has a blind spot. There's one really important place where it's just not the best tool for the job. Any guesses? You got it, the brain. Your normal brain tissue is so metabolically active that it can actually hide small metastases on a PET scan. And that's exactly why an MRI with IV contrast is the absolute standard for detecting brain mets. It has way better sensitivity than a PET-CT or even a regular CT for this one critical job.
Okay, so imaging gives us a ton of really strong evidence, but at the end of the day, it's not definitive proof. For that, you need morphological verification.
In other words, you need a biopsy because, as the saying goes, tissue is the issue.
So how do we get that proof? Well, it all depends on the location. For central tumors, we're talking about a bronchoscopy, sending a camera down the airways. For tumors out on the edges, a transthoracic needle biopsy guided by CT is the way to go. And for those tricky mediastinal nodes, we have specialized procedures like EBUS or EUS. It's all about choosing the right tool for the right spot.
Okay, let's switch gears a little bit. So far, we've been talking about diagnosing patients who already have symptoms. But what about screening and follow-up? How do we find cancer early, and how do we monitor patients after treatment?
20%. Just look at that number for a second. 20%. What do you think that number means in a fight against lung cancer?
That is the reduction in lung cancer mortality, the drop in deaths that we see when we use low-dose CT for annual screening in high-risk groups. A 20% reduction. That is a massive deal. And here's why that's so important. Look at the evidence levels. LDCT screening has level A evidence. That's the highest you can get. It's backed by major clinical trials. Compare that to a lot of the initial diagnostic tools, which are level C, basically expert opinion. This shows just how solid the data is for screening.
So who exactly is in this high-risk group? Well, the criteria are super specific. You're looking at folks between 55 and 80 years old who have a smoking history of 30 pack years or more, and they're either still smoking or they quit sometime in the last 15 years.
And of course, even after treatment is done, the imaging isn't over. A CT of the chest is still the main tool we use for follow-up and for monitoring. It's all about keeping an eye out for any recurrence. So, where does this all leave us? We've gone from a simple X-ray all the way to incredibly precise PET-CT scans and life-saving screening programs. The technology just keeps getting better and more precise. And that leads to a really interesting thought for the future. Could techniques like radiomics get so good that they can predict a tumor's biology just from the images, maybe even replacing the need for an invasive biopsy altogether? Something to think about.